Hi, this is Dr. Schmoe from the Functionality Center. This is our Technologies and TBI mini-series, and today we're going to talk about Virtualis, which is a virtual reality program. It was developed in Paris by a physical therapist, and we've been utilizing the technology over the last 2 years. And I'm just going to go through their Balance VR program, just kind of talk about what it is, and I'll talk about what we do in our office with it. So Balance VR can help patients with obviously balance dysfunction, dizziness, triple PD, visual vertigo, motion sickness. And with it, we're always looking to see, do you have issues with optokinetic stimulation? So one of the very first things that we like to assess is your ability to tolerate visual motion in front of you going very, very slow. And then we check it at different speeds. So we'll check slow, medium speed, and then faster speed. We'll do it in the horizontal, then we'll also do it in the vertical. With the Virtualis, which is cool, we can also check torsional optokinetic stimulation. And you'll see in some patients that feel like very, very imbalanced or dizzy, you might move the optokinetics in one direction, and that might totally eliminate their symptoms, and their balance is better. They feel less brain fog and less dizziness, and they have a better idea of where their body is in space. But when you move it in a different direction, you might see that they might become very imbalanced, very dizzy, develop autonomic based symptoms. And it's different than usually what you think. You'll see that some people will do really, really good with quicker speeds compared. Sometimes it's the slow speed motion that people get that really messes them up, which is kind of counter to what we would think clinically. Usually when things are going slower, they're easier to tolerate. But sometimes it's that slower information when that comes into the brain. And instead of just trying to give them the opposite information to basically balance things out, what we find with the Virtualis, if they have a problem with, say, optokinetics going down, we would want to give them that information until their brain integrates it, but we do it at a rate that hopefully does not overstimulate their autonomic system and push them too far. So we always check optokinetics, and then we also like to check optic flow. So, which is radial optokinetics. So basically the information, how do you do with information that's coming by you? So you're standing still, you perceive that as this information is coming by you, you perceive that you're moving forward, you're translating forward. And you'll see patients start to develop different posturing of muscles. You'll see them start to really grip in with their toes, with their feet. You'll see people become dizzy if it's going forward versus going backwards. And many of our patients that have, say, ESO deviation of their eyes, and when we do a Fukuda step testing, if they translate forward, they will have trouble with optical flow and these radial optokinetics. And we'll do this to basically desensitize their system and improve their ability for their brain to take that information in. We do like to get people driving. So we do like doing motorist looking to see, as you're on the road and as you're moving, do you feel very disconnected? We do have a steering wheel. We like to use basically just like the Xbox controller and have people go through and do rehabilitation on the road. And sometimes you'll see they have a very hard time turning to the left versus turning to the right, and they might become disoriented or feel dizzy. Patients that have vertical deviations or people with central autolithic vestibular dysfunction will sometimes feel very, very uncomfortable on the road. And we want to do therapies to address those symptoms, hopefully get the central integration working better, and then come in and give them the virtual reality stimulation in a way that doesn't overstimulate their system. We don't just put people on the VR if they're not ready for it, if they're not autonomically stable for it. Patients with chronic, like headaches and like have active, migraine that's going on, sometimes they get overstimulated, we've seen with virtual reality. So we're always screening, we're asking questions, we're making sure that we're not pushing people past their limits of what they can handle. We do like to check subjective visual vertical, or SVV, brain's perception of verticality up and down. And you'll see with patients that have had, say, trauma to their inner ear, or have had a brain tumor or surgical removal, or have had a stroke, you'll see larger inclinations in their SVV. Some patients with more central vestibular dysfunction that's in the brainstem and up into the thalamus and into the cortex, you'll just see just subtle changes in their SVV. And we like to use the subjective visual vertical for assessment, but we also actually do it for therapy. So we'll have people seated, we'll put foam underneath them as they sit down, put their feet on an unstable surface, and we'll have them just try and work and figure out where up and down is. And then we'll go in and then we'll actually move their head to help them figure out where vertical is. So we like to do SVV rehabilitation with our patients who have changes in their vertical perception and where their body is in space. If you really want to make things harder, you can actually do a 3D immersion. You can do a dynamic visual vertical where you'll actually rotate the background, and with the background rotating, they still have to find up and down, which is very difficult. The rod and frame test, it's basically a room tilt illusion. Have the room tilted, and even with the room tilted, you're going to have to try and find vertical. And we'll actually use the rod frame test for rehabilitation for patients who have changes in their verticality. Currently, right now, we're not using Schmoe reference visual environment with patients, but we do use C stimulation. C stimulation is very interesting because as we get people out on the water, we can change the wave height, we can change the frequency. You'll start to see all sorts of changes in the descending vestibular reflexes that go with the legs. We always start with people seated, and then we'll move them up to standing, and then we'll have an Xbox controller, and they can actually control moving throughout the waves. And if people have MDDS, if they feel like they're rocking and rolling on a boat, we usually don't put them on the boat again. We try and help with trying to figure out what's the central dysfunction that's occurring and get that better. We might be utilizing gyrostim or vestibular rehabilitation or more proprioceptive-based therapies. In our athletes, though, that we're trying to improve just overall reaction time and function and balance, we really like to use the C stimulation. A lot of our hockey players love it. After doing it, they feel more grounded. They feel like their lower extremity is activated. They feel quicker with their turns and their ability to have just these reflexive activation of their lower extremity muscles, which is awesome. We can have people read in the VR. Sometimes people have a very difficult time reading while they're in the car or reading while they're moving. So we can actually put you in a car reading, and we like to put people on a swivel chair and just kind of have the chair move around and have them work on these visual vestibular reflexes. One of the other things that's very interesting is working with lift. So actually translating and moving people up and down. You'll see all sorts of changes in postural reflexes as we move people up versus moving people down. You'll see people that are very imbalanced, and as we bring them up, they will literally look like they're starting to go like this. And as we bring them down and their feet, legs feel like they're coming back into the ground, they'll feel more steady and they'll feel more grounded. So we use lift for assessment. So we assess people to see if there's any issues with moving in this plane. We also like to obviously put people in the tunnel and shift them forward and backwards. So we want to look at your vestibular system, not only in your typical yaw, pitch, and roll, but also we like to look at translation, we like to look at lift, and then we like to look at fore-aft movement and see if there's any dysfunction that we can pull out and then use it for rehabilitation. Target VR, head-eye coordination tracking for cervical spine proprioception. Basically, a target is moving. You might be in space and you might see basically a planet moving, and then you would have to move your head and eyes and hit the target. It could be a bug. It could be a planet. So we'll do combinations of head-eye pursuits. We can also measure your cervical spine like amplitude, your range of motion. We can measure your ability to come back to neutral and hit a target. So it's just a really good way to start working head-eye reintegration. We can place people in crowds. We can move you through the crowd and actually have people coming by you, moving with you, moving opposite of you. And many of our patients have trouble in shopping centers, crossing the street. So we like to put them in realistic environments once we get them steady enough to be able to tolerate that. We can put people on an escalator. So people that have issues with scrolling, with trying to figure out, are they moving? Is the world moving? People that have trouble in like open spaces, we can basically move them very slow on a travelator or on an escalator. Some patients will have a hard time going down versus going up. It can be the opposite as well. But we like to put them on there and actually test and assess it, and then desensitize their system to that motion. As we're doing a lot of our other rehabilitation, we'll integrate these different stimulations. So that's basically the balance VR. If you go to functional rehabilitation, we'll go here, physio VR. They've developed therapies for balance, hemiplegia, hemi-neglect, coordination, cognitive posture, proprioception. This is virtual reality mirror therapy. So basically, there's a sensor on the front of the goggles. You have your hands. When you move your fingers, the fingers on the screen will look like they're moving. So you can have it set up, or say if you had a hard time moving your left hand, you can move your right hand, but on the screen it will actually look like your left hand is moving. So basically it's VR mirror therapy. And the way that I look at it, it's working the brain bilateral, it's working the corpus callosum, it's working those connections, it's working the cerebellum, it's working the parietal lobe. You can actually do pronation, supination, and hit a ball. So say if you had a hard time with the left hand, you could be hitting the ball with the right hand, and then over on the left side, it will actually look like your left hand is doing it. There's another program we call the electric track. So basically you have the Vive controllers, and then you have to move the controller along a complex pattern, and we can make our own patterns. So we could have you go in there and do a complex design. We could have you do figure eights as you're trying to move through the electric track. If you hit the electric track, then what's going to happen is it's going to spark. So you definitely don't want to hit it. And that's working your motor program, and it's working your cerebellum. We do this on our concussion patients. We use it with our stroke patients, our traumatic brain injury patients. And I'm not gonna lie, this stuff is just actually like really fun. So when people do it, they get excited about it. And there's other things, so we can get playful with the rehabilitation. We can do memorization of like complex like music notes and patterns, start integrating more cognitively. We can do a Bell test to see if maybe you're just not perceiving objects over on one side of your body. Maybe you have a hemi-neglect. We can put you in the supermarket and work spatial navigation and work complex cognitive tasks, and you have to go to different aisles and find different objects and memorize those objects and do them in specific orders. So there are many different programs that are involved with the Virtualis VR, and we've gotten really good at trying to figure out what patients are going to do well with it and who's not going to do well with it. And the patients that aren't going to do well with it, we're not going to put you in there. If your eyes are very unsteady, if you have a hard time with severe, visual motion, we're most likely not going to put you in there unless you're ready for it. So we have to build people up. Our patients are complex. They have horrific visual vestibular mismatches and headaches and migraine. We have to build people up to be able to tolerate the VR. But when we get you there, we see some major improvements in just overall function. We see this function translate out into real world scenarios, and life becomes easy when you can do it in a very complex but also safe virtual environment. So If you have any questions, just feel free to reach out, info@thefnc.com, and we can go from there. I hope you guys have a great day.